We're like a clock. Hi there, everybody. Good morning, good afternoon, or good evening, wherever you are, depending on where you are. And thank you for joining us. I'm Elizabeth Ashbourne, PQMD's Executive Director, and on behalf of the entire team, I want to extend a warm welcome to you for today's Pillar Talk, From Measles to Mpox, the State of Infectious Disease Outbreaks. This session is part of an ongoing series of webinars aimed at addressing major trends, leading insights, best practices, and pivotal issues in global health. For those new to PQMD, we are a global alliance of international NGOs and leading healthcare companies committed to ensuring sustainable access to quality medicines, medical devices, and health services in humanitarian crisis and underserved communities worldwide. Our work revolves around 6 pillars: humanitarian assistance, health system strengthening, disaster response and preparedness, guidelines, knowledge and innovation, and climate and health. Please check the chat for links to our website and more information. Before we dive in, I wanted to go over just a few housekeeping notes. Please kindly type your name and organization into the chat box. We will have you muted, and please remain muted throughout the presentation, but do use the chat for any questions or comments. And this session is being recorded and will be available on PQMD's community of practice later this week. So you're very welcome to share it to all of your colleagues, partners, and friends. So now I'm delighted to introduce Dr. Jill John-Kall, who likes to be called Dr. Jill. She is the Senior Health Advisor at International Medical Corps. Dr. Jill has been with International Medical Corps for over a decade, providing hands-on in-country support across a range of infectious disease responses. With more than 16 years of experience in international health programming, including emergency response, infectious disease management, and health system strengthening. She has worked in more than 15 countries across Africa, Asia, and the Middle East, focusing on improving access to quality healthcare services. Her expertise places her at the forefront of global efforts to combat diseases like Ebola, cholera, and measles, and she will offer invaluable insights into the current state of infectious disease outbreak. Dr. Jill's talks will take us through the current infectious disease threats, from the resurgence of vaccine-preventable diseases like measles to the emergence of Mpox and other viruses. Her deep understanding of the global impact, challenges, and solutions to curb their spread will provide a comprehensive overview of what health professionals are facing today. Once again, thank you for joining us. And Dr. Jill is actually joining us from India. And Dr. Jill, the floor is yours.
Thanks so much, Elizabeth. Hi, everyone. So my name is Jill John-Kall, and as you heard, I'm a Senior Health Advisor for International Medical Corps. And today we're just going to be talking about the state of infectious diseases outbreaks today. And I think, as we all know, infectious diseases remain a major global health threat, with recent surges in vaccine-preventable diseases, vector-borne infections, and re-emergent pathogens. And I think we know, as climate change, conflict, population displacement, weak healthcare systems, and vaccine hesitancy continue to fuel outbreaks, we also know that diseases such as Mpox, Ebola, cholera, dengue, and measles continue to pose a public health threat, alongside emerging and unidentified viral infections. So today we're going to be discussing key outbreaks, some of the response efforts, and the underlying factors exacerbating their spread. In the meantime, if you have any questions, please feel free to put them in the chat. Or if you need to raise your hand, please do. We have people monitoring, and we can get to those questions either during the actual presentation or at the end when we have some time for discussion. And I think there's a lot of people calling in from different places. So if anyone has any specific examples or experiences about the diseases that we're going to be talking about today, please feel free to jump in. It'd be great to get some frontline kind of information and share with everyone. All right, so let's first talk about the key drivers to this infectious disease resurgence, right? So the first one we can talk about is antimicrobial resistance, which I think everyone is talking about now. The growing resistance to antibiotics, antivirals, and antifungals threatens the effectiveness of treatments contributing to the spread of diseases. And you can see that with multi-drug resistant tuberculosis, methicillin-resistant Staphylococcus aureus, and those kind of diseases that have been pretty common over the last several decades. And this is also particularly important in humanitarian settings where antibiotic misuse is really common and people themselves are particularly vulnerable. And some of the contributing factors to antimicrobial resistance include things like overuse and misuse of antibiotics, not just in humans, but also in livestock and agriculture. Environmental contamination, where antibiotic residues in the environment can promote the survival and the spread of resistant genes, infection prevention and control gaps in healthcare, global travel and migration, as we all travel a lot, weak regulations and policy enforcement, and also a lack of new antibiotics, because I think a lot of the pharmaceutical companies lean more towards medicines for chronic diseases. And finally, there's also a lack of awareness and education among healthcare workers, but also the general public, who often pressure healthcare workers for antibiotics, even if they don't need any. And that kind of seems very, kind of ambivalent, but I'll just give you an example. When I was working in Darfur a long time ago, we were short on injectable antibiotics, so we were really pushing to provide oral antibiotics wherever possible. And the community that we were serving, they felt that we were keeping the good antibiotics for ourselves and not providing them to the community. And it became a security issue where they had actually threatened our staff and threatened to burn down, different health facilities if they were not giving the injectable antibiotics. So you can imagine how, if people are not provided the right information, they also don't really understand how antibiotics work, et cetera, et cetera. The next one we're looking at is viral threats. So we are seeing emerging and re-emerging viral threats like avian influenza, viral hemorrhagic fevers, and some of these can be caused by zoonotic spillover from wildlife and livestock with things like bushmeat consumption and intensive livestock farming. I think I read that there's an estimated 60 to 70% of emerging infectious diseases are zoonotic, meaning from animals to humans. And aside from the consumption, they have, wet markets, wildlife trade. There's also encroachment into habitats that all increase the spillover risk. And there's also intensive livestock farming, which can facilitate viral mutation and spread. And it depends on what regions you're in, but it can kind of bring on things like swine flu, et cetera. The next one we're just going to talk about real quick is vaccine access gaps. So declining immunization coverage has led to rising measles outbreaks and polio reemergence in certain regions. And while some of this, among other things, of course, and while some of this can be attributed to vaccine hesitancy, we also have to consider the disruptions to routine immunizations and even shortages of critical vaccines when they're needed the most. And also we have to look at a general inequity when it comes to vaccines, like we saw during the height of the COVID pandemic. And all of this kind of leads to preventable deaths, and that's what we really have to focus on, because those are the worst, is if there is something to prevent a death and we cannot actually make that happen. I think that's really, a pressure point for us to look at. And then we obviously have climate change. We're going to talk about that a little bit more, where rising temperatures and extreme weather events contribute to an expansion, especially in vector-borne diseases. And the last one is actually the misinformation erosion of trust in science. And I think we've really been seeing that a lot lately. The increasing spread of health misinformation, particularly through social media and non-expert sources, undermines public trust in science-based recommendations. So we have influencers, celebrities, and government officials who don't have any scientific backgrounds, and they often shape public perceptions of health, and sometimes spreading misinformation about vaccines, treatments, and public health measures can do a lot of damage. And this erosion of trust can really lead to lower vaccination rates, delayed medical care, and resistance to evidence-based interventions, which all could exacerbate the spread of infectious diseases. So we're just going to take a quick look at how climate change actually affects infectious diseases. So if you look at the screen, you'll see, the first part is, of course, rising temperatures. So rising temperatures expands the range of vectors like mosquitoes and ticks. It speeds up pathogen replication in vectors, and also rising temperatures threaten water and food security, and that can actually lead to conflicts in different countries. And the one thing that, when I was researching, it didn't dawn on me, but I also read that the ongoing melting of glaciers and polar ice caps may lead to the release of long dormant pathogens preserved in ice for millennia. And we've never seen those pathogens. We have no immunity, and we really have no way to prepare, But the rising temperatures basically kind of link in with extreme weather events. And extreme weather events also cause displacement. It disrupts sanitation, increases disease risk, and it also causes overcrowding, which promotes respiratory and skin infections. You also see a lot of rainfall and flooding as a result of these extreme weather events. And you'll see that there's a lot more standing water, which makes it easier for mosquitoes to breed. And flooding also spreads a lot of waterborne diseases like cholera or hepatitis A. And all these things kind of put together, you're looking at an entire ecosystem disruption. So what does that mean? That means that it alters animal habitats, which can contribute to zoonotic spillover of diseases. And it's also linked to outbreaks like Ebola and Mpox. And at the end, you'll see a large geographic spread of tropical diseases appearing in new regions. And now higher altitudes are also at risk for diseases like malaria, where they were not actually at risk before. And underlying all of this, we have to remember that we are working with very vulnerable populations. I think that's something that, if we think about it, we think, oh, it's not just, the people in these refugee camps or IDP camps. They're actually there are poor people, there are people with disabilities, there's elderly people, there's pregnant women, children. There's a lot of different groups that are very susceptible to climate change effects on their own health. And just to talk about, how the impact of climate change on human health goes, you can see from just this slide that there's a lot of different ways how our health is affected. So for example, air pollution can increase, the risk of asthma and cardiovascular disease. The increasing allergens in the air can cause respiratory allergies, again, asthma. We all know that, water quality impacts things like cholera, leptospirosis, Campylobacter. And of course, all of this also goes into water and food supply impacts, and that leads to malnutrition and diarrheal diseases. And in looking at this slide, I want you to also remember that, over 3 billion people live in areas that are highly vulnerable to climate change. And so many people are already experiencing the health effects of climate change. Health-related deaths and illnesses are increasing. Like it says in the slide, there's allergens, there's harmful pollutants in the air, and the same vulnerable populations are also going to be more at risk than everyone else. And so it's important to keep this in mind when people talk about climate change, because I think there's this sense that climate change is more of a political thing. But in all honesty, we have to look at it as something that affects people like you and I, and the patients that we see as well. So I just wanted to give you all a few updates about a couple of diseases that are kind of in the news right now. So we'll just start with cholera. So I think you all know maybe that on March 20th, just a few days ago, WHO released a multi-country cholera outbreak sitrep. And that highlighted that for example, from the 1st of January to the 23rd of February of this year, there's a cumulative total of 70,488 cholera cases with 808 deaths. And that was reported from 23 countries across 3 WHO regions. And so cholera outbreaks have been surging recently, with climate change playing a significant role in several countries. So for example, Ethiopia, Somalia, and Kenya, these nations have experienced severe droughts that are directly linked to climate change. And that has led to water scarcity and contamination, which have exacerbated the cholera outbreaks. In Malawi, they have extreme weather events. such as Cyclone Freddy, and that caused a lot of widespread flooding, damaging water and sanitation infrastructure, and triggering the country's worst cholera outbreak in its history. In Zambia, there was higher than usual rainfall, and that led to overflowing pit latrines, contaminating the local water supplies and contributing to a significant cholera outbreak. In Nigeria, there was also severe flooding exacerbated by climate change, and this also increased the risk for cholera and other waterborne diseases as well. In terms of response efforts, in February, the oral cholera vaccine production remained at a high level, and that kind of reflected the significant efforts that was put in place by the supplier and the partners. And I think that their threshold was having at least 5 million doses on hand for all emergencies. But even with that, the demand is exceeding the supply that it has, because the amount of cholera cases are increasing, as we just watch. So that's kind of the update on cholera. For Mpox, cases continue in West and Central Africa, with some sporadic international spillover as well. And in addition, a lot of these countries are also dealing with other things like other outbreaks, war, et cetera, et cetera. As of late February 2025, WHO continued to classify Mpox as a public health emergency of international concern, with persistent transmission in Africa, particularly the Democratic Republic of Congo, DRC, and Burundi, with imported cases reported in Europe and the Americas. And in the last 6 weeks, I think Uganda also had reported the second highest number of confirmed cases, which constitute about a third of all confirmed cases reported on the continent during the same period, with ongoing increase in weekly incidence, which is really terrifying when you think about it. And just, in general, when people think about, but Mpox, all these countries are so far away, like why should we care, right? But according to PAHO, which is the Pan American Health Organization, in 2025, Brazil, Canada, Chile, Mexico, and the United States all reported Mpox cases, with no recorded deaths, thankfully. And the US reported its third and fourth Mpox case in New Hampshire in January and New York in February of this year. And so response efforts are mainly targeted on vaccination, early diagnosis, and community engagement. But some of the challenges include that there is a limited vaccine supply in endemic regions like DRC and Nigeria. There's still a lot of stigma. There's a lot of awareness that needs to be kind of pushed forward for different, communities, because it really does impact healthcare seeking behavior. In addition, countries like DRC are also experiencing conflict, which negatively affects their ability to control the outbreak using measures like targeted vaccination, early diagnosis, community engagement. And also even Uganda is also dealing with an Ebola outbreak. So you can imagine it's not that easy for countries to just kind of, gain control and really make sure that they can either just control the outbreak or just bring it to an end without any additional support. The next disease that we're going to look at is just dengue. And unfortunately, dengue has an escalating transmission with record cases in the Americas, with severe outbreaks in Brazil, Peru, and Argentina. We're seeing a lot of dengue cases here in India as well. Even Europe is seeing local transmission due to warmer temperatures and expanding areas of the Aedes aegypti mosquito, which is the mosquito that causes dengue. And also urbanization is increasing stagnant water breeding sites. And so that, includes, that increases the risk that people are taking who live around those areas. And control strategies are now looking at new dengue vaccines. So there was, the old one was called dengue vaccine, I think, and that was developed by Sanofi Pasteur. And that was the first dengue vaccine to be licensed. And that was around December 2015. And it was used in more than 20 countries. But in August 2024, the company announced that it would stop producing the vaccine because of low global demand and the availability of a newer vaccine called Qdenga. And in May 2024, the WHO pre-qualified Qdenga, marking it as the second dengue vaccine to receive such a status. And so we're hoping that, the endorsement actually will facilitate broader distribution and use in different countries. And another kind of, mechanism to control this outbreak is something called Wolbachia. And it's just interesting on a side note, but Wolbachia is a bacteria that's found in many insects, but it's not naturally found in the Aedes aegypti mosquito. So scientists introduced this bacteria into the mosquitoes in the lab and then release them in the wild. And the bacteria actually do two important things. One is they block the virus transmission, which is fantastic in itself. But the second thing that it does is that the bacteria is passed on to the mosquito's offspring. So it kind of, replicates, and, all you have to do is monitor it, which is really great because you don't have to keep on, introducing this, this changed mosquito everywhere. It has been significant in Indonesia, where I think it showed a 70% reduction in dengue transmission. It's been used in Brazil, Colombia, Vietnam. It hasn't been used that much in Africa yet, but Djibouti had a pilot program that they started in 2023, and Kenya and Ethiopia are also doing preliminary research on this as well. So, we're hoping that that will bring about vast changes on the continent, because that would be really helpful. And then, of course, Ebola. I think everyone knows maybe by now that in 2025 in Uganda, there was an outbreak, or there is an outbreak, and that's the Sudan strain, which is different from the Zaire strain that was responsible for the largest, the most lethal outbreak, which we saw in West Africa in 2014 to 2016, and then again in DRC in 2018 to 2020. Unfortunately for the Sudan strain, there's no licensed vaccine just yet, even though there is one for the Zaire strain. But in Uganda, officials are now preparing to deploy a trial vaccine as part of efforts to stem this outbreak, as I think now more and more healthcare workers are starting to kind of get affected. So now a range of scientists are actually developing research protocols relating to this planned deployment of more than 2,000 doses of the vaccine against the Sudan strain of Ebola. I think they're also looking at doing ring vaccination, which basically means that it's more of a targeted vaccination rather than a blanket vaccination. So the first group who would get the vaccine would be the contacts of the patients, and then the next ring would be the contacts of those contacts, and so on and so forth. In Uganda, as of today, there's a total of 14 cases and 4 deaths. But unfortunately, this also included a 4-year-old child who was the latest confirmed case, who passed away on February 23rd of this year. Measles, my favorite topic. So I think everyone in the US who's based in the US, and everyone who kind of watches the news maybe already knows this, but there have been major surges in the US and in the UK linked to declining routine childhood immunization rates due to 2 things. One is the disruptions, from COVID, but also due to vaccine hesitancy. And that is really a big concern. Measles is highly contagious with a more than 90% transmission rate in unvaccinated populations. There are severe complications like pneumonia, encephalitis, and death. And aside from mass vaccination campaigns targeting at-risk communities, we're also trying to strengthen routine immunization coverage post the COVID-19 disruptions. The problem is that, as we discussed in that earlier slide, there is a lot of mistrust in science. And I think, unfortunately, now the government in the US is also putting into place people who don't necessarily have the technical backgrounds that is necessary to move public health forward and really protect the population. I also just wanted to give a little update on the big 3. So I think we all know the big 3 is HIV/AIDS, TB, and malaria. While there have been, some progress, we're kind of seeing that progress decline. So, for example, for HIV/AIDS, global HIV infections have declined, but not as steeply as hoped. And around 39 million plus people were living with HIV globally, but there's still a lot of challenges, even though now, you know, HIV and AIDS is kind of, you know, in the common like lexicon, right? But key populations still face high barriers to care. So who are those key populations? Those are men who have sex with men, you know, sex workers, and people who inject drugs. And I think people forget about IV drug use, and they're much more focused on sex workers, et cetera, et cetera. But that is a group that really, you know, does face this issue as well. In conflict zones and among displaced populations, HIV services are often disrupted. So if you're already getting care and there's, you know, a war that breaks out, you know, your care is then disrupted. And you no longer have access to treatment, and then you become worse and worse. And a lot of that does lead to like higher death rates. And the other group that is particularly vulnerable are adolescent girls and young women in sub-Saharan Africa, for all the reasons that we've already mentioned, including, you know, stigma, you know, just lack of access to healthcare in general, conflict, et cetera. For tuberculosis, TB still remains one of the second deadliest infectious disease after COVID-19. WHO estimated over 10 million new TB cases annually, with around 1.3 million deaths per year, I believe. And again, challenges that we thought we would have overcome by now, but drug-resistant TB is a growing significant threat. COVID-19 unfortunately disrupted a lot of detection and treatment, and many health systems are still trying to catch up with that. And children with TB often are underdiagnosed and underreported. And that's also a big issue, because if they don't get treatment as soon as possible, you know, that can lead to them just getting worse and worse and dying. And while doing that, they might also be transmitting the disease to other people who are even caring for them. And for malaria, again, gains have stalled in recent years. There are more than 250 malaria cases globally per year, with over 600 deaths, mostly in sub-Saharan Africa. Challenges are a little bit different than the other two diseases. We have climate change, which is expanding the malaria zones. Insecticide and drug resistance is increasing. And there are a lot of funding gaps for prevention and treatment tools. That includes things like bed nets and rapid diagnostics. And the other thing I just wanted to also bring up is, I think, excuse me, you know, when we look at politics and how politics affects, you know, our public health kind of work, et cetera, I think we all know that PEPFAR was originally launched by George W. Bush, and it was really a cornerstone of the US global AIDS response. And sorry, I'm having some issues.
Thanks, everybody, for holding on. I know that Dr. Jill has some connectivity issues at times in being in India. So if you all wouldn't mind just giving her a moment to see if we can get her to reconnect. Dr. Jill, are you still with us? Can you hear us?
Can you see me?
Yes, we
Yes.
can see you and hear you again.
Sorry. Okay, I think I'm losing my voice. I'm sorry. So now I'm losing my screen. Okay, so we're back to talking about PEPFAR and how PEPFAR, the Global Fund, and other organizations are being affected by all the political changes that we're seeing. And I think we have to think about who those political changes are actually affecting. It's not just us who work in public health, but it's also the people that we serve as well. So, excuse me. So I wanted to talk a little bit about emerging threats. So emerging threats include the following diseases that you can see on your screen. So when we talk about avian influenza, it was primarily in Asia, Europe, and the Americas, but we've seen recent outbreaks in the US, Cambodia, China, and South America. There are increasing reports of mammalian infections in seals, foxes, minks, but they're also raising concerns about human-to-human transmission. And so spread via migratory birds and poultry farming, we're still looking at if human-to-human transmission occurs, then that means the avian influenza has become an entirely different animal, so to speak. So vaccines for poultry exist, but there's very limited human vaccines that are available. Antivirals like Tamiflu can reduce severity, but they're not really widely stockpiled. In addition, surveillance programs are in place, but cross-species transmission risk still remains, and that's not something that we're likely to really catch as quickly as we should. So there's a lot of kind of things like strengthening biosecurity in poultry farms, educating farmers and poultry workers, just at the local level, improving early detection and reporting systems. And then, of course, at the global level, you really have to look at things like increased funding for research on universal flu vaccines and stronger One Health approaches. And I think you may have heard of One Health approach. It's integrating human, animal, and environmental health together. And of course, there has to be international collaboration for real-time surveillance. The Nipah virus is endemic in South and Southeast Asia, but there have been recent outbreaks in places like Kerala and India. And that's not something that you would normally see in this place. It's spread from fruit bats, which is the natural reservoir to humans, via contaminated fruits or direct animal contact. And human-to-human transmission occurs in healthcare settings. Unfortunately, there's no approved vaccine or treatment, but some monoclonal antibody therapies are under trial. And unfortunately, that means outbreak control relies on quarantine and contact tracing. For Marburg disease, I think we've heard of Marburg recently as well. There have been outbreaks in Uganda, Ghana, Equatorial Guinea, Tanzania, and I think recently there was one in Rwanda as well. And this is transmitted from bats through human-to-human contact, often in healthcare settings, due to poor infection control. There's no licensed treatment, but some experimental treatments are in early trials. Again, the same kind of mechanisms need to be taking place at the local level and at the global level to make sure that we have the awareness for public citizens to make sure that they avoid bat exposure. We have to have better infection control in hospitals, and we need funding for vaccine development and training healthcare workers in how to handle hemorrhagic fever outbreaks. The Dengue virus, this is something that I also learned while I was kind of researching this presentation. It was discovered in China as recent as 2022, but it was likely underreported in other regions, and it was believed to be spread from shrews to humans. But so far, there has not been any human-to-human contact or transmission confirmed just yet. There's a limited understanding of the virus, and there's no specific treatments. The treatment is supportive care only. And the last one that I wanted to mention was Candida aureus. It's a multi-drug resistant fungal infection. And we don't tend to think about, multi-resistant fungus when we think about AMR, but it's spreading in hospitals worldwide, particularly in the US, India, and Europe. There's rapid evolution of antifungal resistance, poor infection controls in hospitals that facilitate outbreaks. And although there are some new antifungals that are promising, I think enhanced infection control measures are actually the way to go to reduce these outbreaks. And then on the next slide, we can see unidentified threats. So these are kind of threats that we don't even know what they are yet. So disease X in the DRC in late October 2024, the DRC reported an outbreak of an undiagnosed illness in the southwestern part of their country. The initial case was actually identified on October 24th, with subsequent cases emerging in the following weeks. And by December,
DRC Ministry of Health reported 406 cases and 31 fatalities, primarily affecting children under 5 years old. So they had a total of, I think now we're up to 1,096 cases of an unidentified illness, resulting in 60 fatalities. Many fatal cases progress very rapidly, with death occurring within 48 hours of symptom onset. And preliminary investigations have ruled out Ebola and Marburg, which is what they were thinking that they were in the first place. But unfortunately, a significant number of patients have also tested positive for malaria. So that's kind of suggesting that maybe there's a possible co-infection or a misdiagnosis. But until we really are clear on that, we have no idea what we're dealing with. So that's one of the unidentified threats. And the other unidentified threat is bioterrorism. And I think we've seen that in, recent years with the different wars that we've been seeing. There are high mortality rates. They're looking at ease of dissemination and potential for severe public health impact. And for example, some of those diseases that can be used as a bioterrorism weapon are things like anthrax, smallpox, and plague. So what's next? That is a great question. I think my slide is kind of crooked, but anyway. So what we're going to be seeing, I think, is climate change, rising vaccine hesitancy, and vaccine shortages are going to further worsen public health risks and disease outbreaks. Ongoing conflicts will continue to weaken already fragile healthcare systems. And, that's going to be further exacerbated by restrictions on humanitarian activities. And for all of this, infectious diseases are going to continue evolving. And so we have to think about how we can stay prepared and how we can kind of focus on what's ahead. And so some of those things that we can do are in this slide. So we can work against misinformation. I think that's one of the key factors that we're seeing. And that kind of goes, it runs the gamut from vaccine hesitancy to, pressuring healthcare workers for antibiotics, even if you don't need it, to healthcare workers actually writing prescriptions with 3 or 4 different antibiotics when, maybe just one is needed, if that. But we really have to kind of start really educating people. And I think that's going to be a little difficult, especially in the US, given our current political climate. But I think those in global health really need to push this forward. We need to be investing in local surveillance and, rapid response mechanisms to detect and contain outbreaks early, because once they're really out of control, geographically, a lot of countries have issues because a lot of their more rural areas are very underserved and they don't have the staff or the logistics to go out and actually control outbreaks in those particular areas. Increased training, improved surveillance, and improved medications to combat antimicrobial resistance, increased vaccine access and production in the global south. So that's actually a big thing that should be happening. And I think that should have been happening a while ago, to be honest. No matter what, we do have to recognize that climate change work is important, not just for all the other reasons, but just from a public health perspective. And we talked about that earlier. Support the One Health approach, as we said before, because we are seeing a lot of zoonotic transmission. And what we really don't want is from animal to human and then from human to human, because that's really what drives a lot of these outbreaks. And then strengthen global collaboration. Probably not the most popular idea right now, given the US government, but for everyone else, I think it's still a great idea. Bring on WHO, CDC, African CDC, all those groups together can help, coordinate and bring about a more effective response, because there's so many different pieces to a response. And I think that kind of gets lost in the middle of, all the politics and everything else. And I only have one more slide, and that slide is this slide. And I don't know if anyone who's listening on the call, does anyone know what this slide is about?
I do, but I cheated. I saw the answer.
Oh, Victoria, no, you can't cheat. So
Don't be shy.
anyway, so is anyone trying to answer? I can't see
There is
if
a
anyone.
response, actually. Kim Keller just said polio with Elvis.
You bet.
Yeah,
Absolutely.
vaccine hesitancy. Yeah.
So, exactly. So in 1956, Elvis Presley got a polio vaccine on national television to help inspire other people to do the same, especially teenagers, because I think they were very, like, well, who needs a vaccine, blah, blah, blah. But I really, and I learned about this when we were doing COVID training several years ago, but it sat with me because I thought, if someone like Elvis, if we had Elvis today, I think maybe things would be different. But I think this is an example of how, we have to kind of think a little bit outside the box, and maybe really kind of try to figure out how to get the message across in a more appropriate way than maybe we would think, would be. I'm sure that when the first public health person went and said, oh, let's get Elvis to do this, I'm sure many people said, no way, that's ridiculous. But it seems that after this happened, there was an increase in people receiving the polio vaccine. So I think for me, like this guy, he gets a lot of credit for a lot of things, but I feel like from my perspective, this is one of the best things that Elvis has ever done. And so I hope you can appreciate that too. And I think that is my time, and thank you very much.
Thank you so much, Dr. Jill. That was incredibly informative and really interesting. And currently, we have a message in the chat from Dr. Uche. She says, really appreciating this conversation, Dr. Jill. And many of the geographies where we work, we're seeing how these outbreaks are driven by a combination of climate stress, weak health systems, and community mistrust. One area we're leaning into is more RCCE, risk communication and community engagement, not only as a tool for outbreak response, but perhaps a longer-term strategy to build or rebuild trust and address issues of vaccine hesitancy. Curious to hear your thoughts on how we can scale effective, culturally grounded RCC approaches, especially in communities facing reoccurring outbreaks.
So that's a great question. And I think we did, I mean, for me, the first time I really came across this whole vaccine hesitancy issue was actually during COVID. And so we did a lot of work in different countries to figure out how to get the message across in the best way possible. And so when you look at, risk communication and community engagement, I think the place to begin that is actually in the communities. I think it should go from bottom up rather than top down. I think we have to have people go into communities that, and maybe recruit from those communities to really get a sense of what their understanding is, how is their health literacy, and how they would prefer to receive the information. So for example, just between my family, there are some people that prefer to receive text messages. There's some people receiving emails, and some people would rather go to their healthcare provider and hear it directly from them. One of the things that we also did was when we did training for our healthcare workers on COVID, we gave them a little pin to put in their lapel of their lab coat. And the little pin just meant that they were trained in COVID. They understood it, they understood what it was about, et cetera, et cetera. And so, when people started asking what that pin was, word got around to other health workers as well as patients. So then the patients also felt very comfortable going to these particular doctors because they knew they had gotten trained. So their level of trust had increased just by seeing a little pin, But I think there's a lot of different ways, and that idea came about from just asking communities, who do you trust? And we did we did several vaccine hesitancy surveys, and part of that was actually trying to figure out, from the communities that we serve, what is their understanding of, whatever disease it is, and how we could best get that information to them in a culturally appropriate manner. And I think, just from the question, I'm assuming you have a lot of experience as well. And I think one of the examples I could give you is during Ebola, about burying bodies, because that was also a big issue in the beginning, where people were upset because when their loved ones had passed away, they wanted to do their, traditional burials. But then quickly it was noted that that was getting everyone sick and spreading the disease further, et cetera. And I know that there was a lot of work done. So this is all just to say that for me, I think it really begins in the community and then go outward. Because if we're not communicating and engaging with the community in a way that they accept, then I don't think we're going to go very far. And I think just on another tangent, I think we also have to note that there are going to be people who are going to be against this, and that's fine. And I think, you know, rather than kind of turning on them, I think we have to at least say, okay, if you are against this, that's fine, but then really work on everyone else, because a lot of people, sometimes they change their mind if they see that all their neighbors are going to, you know, get vaccinated or are following some other kind of public health intervention. Just that kind of silent peer pressure might work as well. So yeah, I don't know if the person who asked the question, if you have any examples that you might want to share.
Yeah, thanks a lot, Dr. Jill. I was going to just send a note to say I'd love to follow up with you maybe subsequently. There's just so many questions and comments, but really, really enjoying this. Yeah, I think for me, the experience has been more around COVID and, you know, happened, we're responding in Nigeria specifically. And we had a lot of wastage of the vaccines because of the mistrust, with all the myths and misconceptions around, you know, it's going to reduce the fertility, you know, it's going to make the, you know, your kids autistic. You know, there's a lot of myths and misconceptions around vaccines. So, you know, with vaccination specifically, there's demand and there's supply, right? So even if we work on the supply and, you know, we have issues with the demand side, then, you know, we failed as, you know, on the program. So just thinking through what makes sense to really, so are we integrating some kind of behavior change messaging, you know, in our RCC approaches as well, you know, so that we can, you know, people to uptake the vaccine. So there's a whole lot, especially when you go closer to Africa, you have a lot of, you know, vaccine hesitancy issues, and you end up, the vaccines end up wasting, you end up trashing them because they expire, people are not taking them, and you have really low vaccination rates. So I think it's something we need to really pay attention to, in addition to all the other, you know, approaches and strategies, but really, really, yeah, thank you.
Yeah. And I can give you an example just from my own family. So we are a science family. We have, you know, a lot of science people in my family, but WhatsApp was just a disaster during COVID because everybody was just forwarding whatever messages were going on. And even my mom, who has a science background, she started sending my family things about COVID that, you know, if you, you know, put a little turmeric and in warm water with garlic and drink it, you know, and I was like, Mom, but you yourself have a science background. And, you know, her feeling was, you know, oh yeah, but if it helps somebody. And I said, but I mean, it's not going to, you know, but so it's important to have these kind of conversations, not just in your own family, but, you know, outside as well. And you know that if you're facing these kind of issues in your own family, you can imagine how much harder it is outside. So I agree. I think it's, you know, it's really something that we have to come together on to really see an impact later on. And it would be great to get in touch with you because I'd love to hear more about what you've done for sure. And thank you for your question. I appreciate it.
Yeah, thank you. What I want to touch on is you talked about the outbreaks and emerging infectious diseases we're seeing with climate change and the likes. One of the things we started doing recently was infectious disease prioritization, you know, moving out of, you know, your traditional HIV, TB, and malaria, but, you know, just identifying per region, per country, you know, what are the emerging infectious diseases we're seeing and why. That way, you know, our approaches or strategies can be very contextual and tailored. So I'm happy to share that with you and the rest of the PQMD team as this evolves. So really grateful for this. Thanks.
Great. Thank you so much. I look forward to getting in touch with you.
It'd be great, Uche. Thank you. Great to see you here.
Thank
Are there
you.
any other questions maybe?
I was going to take the liberty to see to ask a question myself if no one else has something to pop in. And I actually have two questions, and feel free to either pick or answer both or whatever you'd like. But one is just with the restriction and funding that is happening, and you have a lot of ministries of health having to make really, really difficult decisions as to what they fund. And I know that in your list of things that we could do, there were quite a few things. And so if you are giving advice to the Ministry of Health, how would you prioritize these resources, these limited resources? That's question number one. And question number two is, that was a heavy presentation. I know you deal with it all the time, but it's definitely, you know, and do you have any bright spots or any optimism or anything that you're looking for that you feel optimistic about, that we could maybe leave people feeling that we could work collaboratively together on pushing or scaling something, or just some optimism? So feel free to pick whichever you want, or answer both, but those are
I'm
my
going to answer the
questions.
first question first, and then I'm going to hope that there's a technical glitch that prevents me from answering the second question. Okay, so the first question is what advice I would give to the ministry about prioritization. So that's really hard because I think that, to be honest, I feel like the ministries mostly know what their priorities are. And I feel like people like me should be supporting them in kind of looking at their priorities. So I'm pretty sure they already know, but I think they're going to have to make a lot of hard choices. And I think that's unfortunate because, you know, while we have this whole presentation was about infectious diseases, et cetera, you know, and it is, you know, a threat to, you know, our global community, et cetera. But on the other hand, they also have to look at things like maternal and newborn death. You know, and I think, unfortunately, you know, the things that you can see are probably going to get more attention than the things that you can't see. You can't really see climate change. So some people are like, okay, but is it real? You know, we're talking about, you know, the changing in, you know, the mosquito breeding sites. And a lot of these concepts might be a little bit more abstract, rather than if you go to the lay board and you're looking at, you know, how do you deal with postpartum hemorrhage and those kind of things. And so I think the ministries also will have external pressure. And I think really the only way to kind of combat that is, as a global community, to really put, you know, our funding and our willpower behind, you know, our evidence base, and really kind of, you know, bring together as much evidence as possible and present it to the ministries, help the ministries, you know, kind of look at their own data and see what they have. I think this is where we can probably help them the most, because it's hard to tell them to prioritize one thing when so many other things are happening. You know, in Uganda, in DRC, I mean, in DRC, they're dealing with Mpox, they're dealing with some other mystery, they're also dealing with conflict. They also have a very, you know, years and years of kind of, you know, a weakened kind of health system, you know, and it's a large country. So just from a geographical perspective, you know, so there's so many different layers. So I think my advice to the ministries would be probably, how can I help you, to be honest? Because that way, at least we can kind of look at what they need to do immediately, and then maybe more intermediately. And if they need to focus on something right now, if we can, as a global community, help them prepare for what's coming down the line, maybe that's the way to go, especially with reduced funding, for sure. I think your second question was about saying something positive. So I live in Austin, Texas. And so I was at home for a while before I came to India to visit my family, and there was not a lot of positivity at home when it came to public health in general. I think we all know what has happened to CDC, et cetera, but I think, I don't know, I have to think that I've been doing this kind of work for 20 years. And every, you know, few years, I always see something that happens and I'm like, oh my God, this is the worst that could ever happen. And you know what? It's never the worst, you know, and then somehow we kind of get over it. You know, so I think my light at the end of the tunnel is that I think whatever damage, and I'm using that word very carefully, whatever damage is done over the next several years, it will be really difficult. But I think at the end, there are people now that are getting into global health, you know, and those are the people that will be able to fix these issues, you know, because at the end of the day, regardless of what we hear, saving lives is something we should do. I mean, that's the end of the, you know, that is it. Like, we should be saving lives, whatever it takes. So it's going to be rough, but I do see some light at the end of the tunnel. I don't know if that answers your question or not. I'm trying to be as truthful as I can.
No, I appreciate that. I definitely appreciate that.
Oh, but I will tell you, one thing that I am like really looking forward to seeing, and I hope this doesn't go haywire, but I do think that we can use artificial intelligence to actually help us with moving forward. And I am not an AI person, but the little that I use ChatGPT for, it's, you know, you can see how it can really help kind of move forward, either, you know, analyzing data, analyzing, you know, what will make the biggest impact. Any of those kind of things. Looking, even pharmaceutical companies can be using AI to see, you know, what are the best ways to develop vaccines, new antibiotics, all those kind of things. So I think for me, at least that's one light at the end of the tunnel. But I don't know, does anyone else on the call have any lights at the end of their tunnel?
Very optimistic crowd, you can see. We've got about just a few minutes left, so I really wanted to thank you, Dr. Jill. If anybody didn't have any questions, maybe just turn it over to EJ for a few closing comments.
Oh, okay. Well, thank you. I was just thinking, I was about to say, should I say something optimistic? But what I find is optimistic is, or how I am optimistic is that we're all on this call, that we're all talking to each other, that we're listening to each other, that we know that there is a path, and that really any one donor, any one country really is not, I mean, yes, it will have a varying degree of impact, but it really is not going to chart the course for the global response to public health. It's not the only thing. So I think new donors will come into the fold. I think people will step up that we maybe didn't recognize. I think that there is hope among our members, and I see it every day. Things that really surprise me, people that we didn't know were in the mix, come to the fore and make a really big difference. So that's my hopeful message for this. But I also want to say I'm really appreciate, Dr. Jill, your incredible presentation, the diversity of the experience and the information that you offered, I think is incredibly helpful. It was such an interesting group of people who joined the call today. So thank you so very much to everybody. And, stay tuned for more of these sessions as we have them throughout the year. And for those of you who have not yet signed up for our Global Health Policy Forum, who haven't looked at the agenda yet, we have some incredible speakers. We have some amazing content that we will be discussing, and participants who have already committed to joining us, including many people on this call. So we really look forward to seeing you in London and hope that you'll be able to make it. And again, Dr. Jill, thank you for making the time for us. I know it's quite late there. So really appreciate it, and International Medical Corps for supporting this pillar talk. So look forward to seeing you soon.
Thanks, everyone. Have a good rest of the day or evening or night. Bye-bye.
Okay. Bye.
Thanks so much. Bye-bye.